So, good evening, everyone. So, welcome to the first North Zone postgraduate teaching class for 2021. And we received so many requests from our postgraduates to start this again, like the last year. And therefore, we started. It's a high time to start the online classes because this year also all the exams of MCH or DNB exit exams will be virtual exams. So, I will first of all invite the President of NZUSI, Dr. Sudhir Rawal sir, to give his inaugural address.
Thank you, Anup, and welcome everyone. Dr. N.P. Gupta, Rajiv Sood, Mallikarjun, and Keshav Murthy, um Samir Trivedi, and Prabhujot and Himanshu. It's my pleasure to invite you for this webinar, but there we know that how the environment is there in whole of the country. The people are dying and we are struggling with this pandemic. But in that pandemic, I appreciate Anup, who is still working, and the life has to go on. If you are alive, you have to live. So that's what Anup is doing, and we are here. And it's a great thing that our postgraduate asked for this thing. So, and I am sure the teachers like Dr. N.P. Gupta, Rajiv Sood, and Samir Trivedi, and moderator Prabhujot and Himanshu will give you a real good knowledge of how to, in the urology and all aspect of urology, so that you will be learning a lot. They are all experienced teachers. Uh, as far as future is concerned, we don't know, but we hope that everything settles and we're going to meet in person with each other. But till that, stay safe, take care of yourself and your family and friends, everyone. Thank you.
Words. So now I will invite our President of USI, Dr. Mallikarjun sir, for giving his inaugural address.
Thank you, Anup, for inviting me for this event. I echo the sentiments of Sudhir. I think we are not in a jubilating mood today on any day. We are just laughing out from our minds, but not from our hearts. We know what the pain we are going through ourselves and our countrymen, our members of the society everywhere. At one point, we are losing our friends, family members, etc. At the same time, this is the only thing I think possibly a medical profession is doing now to get a little amount of rejuvenation to be back at work. Somebody was questioning whether we need these programs at all at this point of pandemic. I think every human being like us, most of the time we are involved into this academics other than the profession, nothing else we have to do ourselves. Possibly this rejuvenates us to certain extent and go back us to do the job next day in the morning. So all the best to you all people. And I think the postgraduates, especially this year and the last year, would have been a difficult times with losing a lot of clinical work and a lot of teaching programs and workshops, etc. But anyway, I think both the national council and the state zonal councils are doing a great work in spreading this teaching programs online, if not live. Online they are happening, and possibly they will be helping us in near future. And hope all of us will stay healthy and stay safe. Thank you very much, Anup, for this opportunity.
Thank you very much, sir, for your such kind words and for encouraging our residents. Now I will invite the Honorary Secretary of USI, Dr. Keshav Murthy, sir. He has been a very dynamic Secretary of USI and has been helping the North Zone in all the activities. So I will request him to give his opening remarks. Dr. Keshav Murthy, sir.
Thank you, Dr. Anup, and it's my pleasure to be part of this webinar. It's I know North Zone is doing a lot of teaching activities, although virtually now, but I think the residents will have to learn this way because in this pandemic, the exams are also going to be virtual and it's quite a different format. They would not be used to this teaching. We need to emphasize this part of the teaching for them so that they are confident when they come to the exam. They would not have been trained in this virtual online exams. So I think these would be of help, immense help to them. I wish all the students all the best and this program also all the best. Thank you, Dr. Anup, over to you.
Thank you very much, sir. So now we are going to start the program. We have the three very eminent teachers today. They do not need any introduction, but just I will introduce them. Professor N.P. Gupta, sir. He is the teacher of teachers, and we call them the Guru Dronacharya of all the urologists, including myself. And he has a great passion for teaching the residents, and that's why he's always ready whenever we request him to join us. And that's really his greatness and his passion for the teaching. Then we have Professor Rajiv Sood. Again, he doesn't need any introduction. He is again has a very high passion for teaching, and he is the chairman of our Indian School of Urology also, and we know what excellent things he is doing. So we are blessed to have him here. And then we have Professor Samir Trivedi also, who is again excellent academician working in BHU, and he again has a very high passion for teaching. So I think we have three excellent teachers for all of you residents to teach you. And then we have two excellent moderators, Professor Dr. Prabhjot Singh is the additional professor, AIMS Delhi, and Dr. Himanshu Pandey, he's at AIMS Jodhpur, head of the department. So what we are going to do, Dr. Prabhjot is going to start the first case. We have 60 minutes for one case, and there are three residents allotted to first case, 20 minutes each, one by one, they will call them, and our faculties are going to take their viva sequentially. And in the end, we are going to give some take-home messages for that particular case, and it will be like a mock exam. So let us start. Dr. Prabhjot Singh, over to you. Now you can start sharing your screen. And the first batch we have Dr. Devendra, Dr. Samarth, and Dr. Gagan. So you please keep your audio video on. And now Dr. Prabhjot is going to start, and over to Professor N.P. Gupta, sir.
Thank you, Dr. Anup. So we'll start with the first resident, Dr. Samarth. So this is our first case. So he is a 73 years male who presented to your OPD with a hematuria for the last 1 year. So what leading question you want to ask? Dr. Samarth, please unmute yourself. Yeah, you are audible.
Yes, so I would like to characterize the hematuria. I would last ask whether the hematuria was initial, terminal, or throughout the maturation, whether it was associated with clots or not, whether he had any retention of urine associated, any history of hematuria in the past, whether he's having any associated lower urinary tract symptoms, whether or not he is a. These are the initial questions I'd like to ask.
I will request Professor N.P. Gupta, sir, to start asking the questions now. Dr. Gupta, sir, please unmute yourself.
There was some interruption, so I couldn't hear properly what he said. Can you repeat, please, what more you like to know in this case?
Yes, sir, sure. The hematuria further, sir. I would like to ask whether the hematuria was initial, terminal, total, whether the hematuria was associated with clot, whether he had any history of retention of urine associated with hematuria, whether he underwent any intervention or catheterization for the same, whether he has any history of trauma, any history associated, or he has any associated complaint tract symptoms or flank pain associated.
Would you like to ask also for history of smoking?
Yes, sir. So I'd like to ask whether he continues any form of tobacco in any form, either smoking or chewing or any other form.
You like to ask if any treatment has been given in last 1 year?
Sir.
Or any investigation have been done in last 1 year?
Yes, sir.
Hello?
Yes, sir.
Okay, Prabhjot, you take over. Prabhjot, you can continue.
Unmute yourself, Jyot, unmute yourself.
Unmute karo, Prabhjot.
Prabhjot, please unmute yourself.
Yes, sir. Yes, sir.
Now,
So this patient had painless, gross, intermittent, total hematuria, which was associated with the clots, and shape of the clots was amorphous. He had a history of lower tract symptoms, mainly frequency, dysuria, staining to void, but no other lower tract symptoms. No history of retention, flank pain, lithuria, fever. No history of any metastatic symptoms like shortness of breath, chest pain, bony pain, hemoptysis, seizures, etc. There is no history of any constitutional symptoms. But the important thing is blood thinners. He's on blood thinners. So I think this history is very important.
Okay. What next you like to know more information about this patient?
Yes, sir. I would, as I already asked, I would like to know whether he trauma. That is one, and second thing is whether he is a.
See, I tell you one thing that there are two types of things in the history taking. One is positive and negative. So positive thing has been told to you. Now why you have to go back to the trauma? If there would have been history of trauma, he would have already told you there's a history of trauma. So don't waste your time in these negative questions. You can go ahead like a comorbidity. You have seen the next slide. So it is more important for you to know whether he has got any comorbidity and what medicines he is taking. Yeah, next slide, Prabhjot.
So he's a known diabetic for the last 10 years. He's on OHAs and sugars are well controlled. He's a known hypertensive for the 5 years on metoprolol and amlodipine. He's a known CAD but unstented. He's on ecosprin and clopidogrel for the last 3 years. And as sir asked, there is a history of some endoscopic procedure outside your hospital 2 months back, which patient doesn't carry any papers and no other surgery in the past.
Prabjot, you can continue, because you can ask questions also. I will give
Okay.
only extra comment at the end.
Okay. So what next you will ask, Dr. Samarth? What is more important in smoking? What are
the factors of smoking, whether he is reformed or not, or whether he is still any occasional exposure, any such occupation is working very to chemicals, and positive family history of similar complaints in anyone in the first or second degree relatives.
So what do you think? What are the etiological factors which are well established for the bladder cancer? Can you enumerate them?
So smoking is the foremost, which smoking in any form, whether tobacco or cigarette smoking or hookah smoking, exposure to naphthalamines or aromatic amines in the form of exposure in chemical industries, paint industries or dye industries.
I'd like to just interrupt. See, the question was asked to you, what is the importance of smoking in bladder cancer? So you have to limit your answer to the smoking only, and why you have to go into the other things, Again, you are wasting your time. So what is the importance of smoking? Is the duration of smoking and the number of bidi or packs or cigarette smoking is important? Or you think he's an occasional smoker or a chronic smoker? So these things should be asked actually. Go ahead, Prabhu.
So he's a known smoker for the last 20 years. He's a bidi smoker, 2 pack per day for the last 20 years. He's a known alcoholic, married having 2 children. He's a farmer by occupation. There's no drug allergy, and family history is not significant. So what next, Dr. Samarth? What you would like to do in this patient? This patient is in your OPD with this much history.
So I would like to examine the patient first. Hello.
So tell us about what do you want to examine?
In general physical examination, I would like to look for any lymphadenopathy which is evident in the patient. Any evidence of pedal edema or facial puffiness which could suggest death for the patient. Any evidence of suprapubic fullness which could suggest retention in the patient, which could be associated with clot retention in this. These are the salient things that I'd like to examine for internal examination.
Dr. Samarth?
Yeah.
Sure.
Yeah.
What are your possibilities? What are you thinking based on the history?
Diagnosis would be a carcinoma bladder.
Okay. Second?
It could be a vesical calculus, which could be associated.
Vesical calculus. painless hematuria for 1 year without significant LUTs. Because your examination, what you want to know, would be based on what is the list of diagnosis that you have in your mind, right?
Yes, sir.
So you have to ask accordingly. If the question is asked, what do you know, what you want to know about in the examination, you haven't mentioned the renal angles, there might be an RCC. There might be clot retention with fullness of the upper tracts. The patient may be having CA prostate on DRE. So there are a lot of things which need to be looked at during examination. Okay?
Yes, sir.
So prepare a list of, don't keep just one diagnosis in your mind just at the end of your history. There has to be 3-4 possibilities, however far-fetched they may seem. I know that the dictum is any paleness hematuria above the age of 50 should be considered as malignancy of the bladder unless proved otherwise. But you need to have a list of provisional diagnoses.
So this, should I proceed, Dr. Sameer? So this patient on general examination is everything is normal except for the mild pallor. Chest is okay, CVS is okay. Per abdomen, it's a soft, non-tender, and there is no mass is palpable. External genitalia meatus is normal, urethra is normal, hernia orifices are normal. On digital rectal examination, there is a grade 2 firm prostate and non-tender. So as Dr. Sameer suggested you that if there is a RCC in your differential diagnosis, you should have find some mass. May find the mass if it's a locally advanced RCC. So differential has to be kept in your mind. Okay, what next?
What next?
So I'd like to investigate the patient further. I'd like to ask for a urine routine microscopy. If the hematuria is settled, I'd like to advise for a UG, 3 specimens. I would like to ask function test, complete blood count, and ultrasound the whole abdomen.
You said urine RM, and then what else do you want?
Function test, CBC,
renal function test.
urine,
Okay.
Urine cytology,
Urine
and
cytology.
ultrasound.
Okay.
So hemoglobin is 9. Rest of the parameters are almost normal. His serum creatinine is 1.1. LFT is normal. Urine routine shows the RBC plenty with pus cells of 6 to 8. Culture is sterile. HbA1c for the blood sugar is 6.4 and FBS is 146. Dr. Smart, can you tell me that if the patient is having plenty of RBC in the urine, it's a gross hematuria, what is the utility of doing urine cytology?
So we can use a Carnoy solution to lyse these cells and look for atypical cells in case of suspected malignancy, which could help to know whether the disease is high grade or not.
So would that be your standard practice in all patients? Would you make that effort to do a urine cytology?
I didn't get your question.
Would you like to do this in all patients who have got hematuria?
Yes, sir.
So you can't wait for the hematuria to settle down or look at your imaging results.
Yes.
And get a window when the hematuria is all not there, then do a cytology.
Dr. Sumat, Dr. Sameer is asking, you want to do some imaging first and diagnose as a bladder cancer, then do cytology, or you do in every patient cytology? Any hematuria?
Actually, I mentioned initially that if the hematuria is settled, then I'd like to advise for a urine cytology, and I'd also like to get a ultrasound whole abdomen done.
Are you satisfied before doing ultrasound? Are you satisfied with these investigations, or anything more you want to do? Hemogram is complete, whatever you wanted. Do you want anything about prothrombin time or any other thing? Patient is on ecosporin and blood thinners. And patient is having hematuria. You don't want peripheral smear or anything
Yes.
in the blood and coagulation profile, anything, because patient is on blood thinners, double blood thinners. What you will like to add to your investigations?
So I would like to ask for a bleeding time, clotting time, and APDT times.
So that is important because patient has bleeding, and 2 months back patient had some surgery also. Whether that was complete, incomplete, what kind of surgery was there, that is a different matter. What do you know about delayed bleeding? For how long it can happen? After till 2 days, till 1 month, till 1 week, till 5 days, till the blood thinners are restarted. At that time it can start. Anything can happen. So some of the investigations are mandatory.
Sure.
You have to take decisions. Okay.
Yes.
I think now we can shift to the next student. Dr. Gagan can take over from Dr. Samar. And I will advise, please use earphones so that we can hear you loudly.
Dr. Gagan, are you there?
Dr. Gagan, please unmute yourself and be ready. You are ready?
Yes, sir.
Yeah, okay.
Please read the ultrasound and can you see the screen?
We cannot hear you, Dr. Gagan. Unmute yourself or you remove your earphone. I don't know what is the problem. We cannot hear you.
Am I audible now, sir?
Speak loudly so that our teachers can hear you.
Am I audible now, sir?
Yeah, now continue.
Yes.
Yes, sir. So in the ultrasound, we can see that both the kidneys look normal. There is no hydronephrosis. But in the bladder, we can see a large bladder mass located on the lateral wall. The prostate appears normal and homogeneous.
Which lateral wall is it, Dr. Gagan? Right or left?
So it's a left lateral wall.
Any more information which you'd like to share with us? Is it a broad-based mass or a papillary mass?
So it appears to be a broad-based mass. It's a single mass. There doesn't the ultrasound picture does not show any other mass in the bladder, and there is no proximal hydronephrosis.
What are the features of a broad-based mass in this?
It is the pedicle. Sorry, sir. It's just that the attachment to the bladder does not show a small pedicle.
So what it is showing is important because it is not showing anywhere the broad base. Whatever you are saying, yes, it is a reasonably large mass, maybe 5-6 centimeter, but the base is smaller than the mass, and you cannot see in these images where it is attached exactly. And wherever you are seeing, it is not broad base, as per my understanding. Rest Dr. N.P. Gupta can comment, or Prabhjot,
No.
you can.
No, there is no doubt that size is a large, but commenting on the whether this is narrow pedicle or something is difficult only on ultrasound basis. So I think so we should only tell what is possible in a particular investigation. It is not necessary that if examiner asks some question, so you have to answer. No, it is not necessary for you. You can say, sir, I can make out this much. And then what next you want after this? This investigation, I mean to say.
So in your presentation, you have told that it is broad-based mass that should have been avoided.
Okay, sir.
What next do you like to do in this case?
Sir, in this case, I would like to get a CT abdomen plus KUB with CT urography and a chest X-ray.
Okay, what are the indications of CT scan in bladder tumor?
According to recent EOA guidelines, CT scan is done in case of multiple tumors, in tumors which are greater than large tumors greater than 3 centimeters, tumors located near the bladder trigone, or if we have a cytology of high-grade tumor, or if there is proximal upper tract changes of hydrouretonephrosis.
So according to these indications in this particular case, you think we should do CT scan or we can go ahead with a TURBT straight away?
In this case, since the tumor appeared to be a large size, I was recommending a CT scan. I would have done a CT scan.
Okay. And what is the advantage of CT scan before TURBT?
Sir, if
we can do it later on also, depending upon the histopathology.
Yes, sir, but the treatment can vary. For example, if the information that we get from CT scan can change whether we want to go for a complete TURBT with post-op installation, or we can straight away go for just TUR biopsy.
Really?
Okay.
Based on CT scan, you can decide whether it is muscle invasive or non-muscle invasive?
Not muscle invasive, non-muscle invasive, sir. But yes, T3B scan, T3B and above can be seen on CT scan.
So if the CT gives you a finding of T3 and above, you will just do a cold cup biopsy, you will not do a TURBT?
And T3B and above, yes, sir.
Based on the CT scan findings?
Yes, sir.
Have you heard of staging TURBT?
Yes, sir. I have heard of stage TURBT. Yes, sir. We could do a
No,
stage TURBT.
one thing you should know that there is a limitation for every investigation. And that's why now we have got MRI also available. So if the only CT scan can predict muscle invasion if tumor is going out of the bladder. If there is extra vesical extension, then you can be very sure that yes, this patient has got a muscle invasive disease. Otherwise, you cannot be dogmatic. So first you see the CT scan, complete CT scan, and then you can make a comment like this, what you are saying actually. You know? So, okay, we can read this CT scan, what has been shown to you.
We have two films. This is the first film. Read this film first.
In these films, there appears to be a large mass on the left posterior lateral wall of the bladder. Although not very sensitive or specific, but the bladder wall appears to be does not appear to be extending beyond the bladder. There is no proximal hydrouretonephrosis, and it's a single mass.
And it's a pedunculated or wide base. Now you see carefully.
There appears to be pedunculated.
Yeah. Okay, what next now after this?
Sir, after this, now I would like to, after this, I would like to get a chest X-ray done. And after chest X-ray, I would like to go for a cystoscopy and biopsy.
Now, I'd like to point out you here one thing, that there is, when we ask what are the investigations to be, I'm talking in general in any case in examination. There are two types of investigation. One is a diagnostic to come to you so that you can clinch your diagnosis as early as possible. And there is a second set of investigations which are done to check whether patient is fit for any kind of surgery or not, depending upon his comorbidities. So when initially your question was asked how you will investigate, first you should focus only on diagnostic. Now, after seeing the CT scan, he has got comorbidities. He has coronary artery disease. You didn't mention anything. I like to do a medical checkup to see the fitness for operation. Will you like to do that or no?
Yes, sir. Since he has CAD but has not been stented and is on blood thinners, I would like to get a complete evaluation and fitness done before scoping.
Now, one thing more I like to highlight here. Here lies the importance of your blood thinners. So what you like to know about the blood thinners in a particular patient whom you are taking for surgery?
I would like to know which thinner exactly is he taking. Is he taking just aspirin or is he taking aspirin plus clopidogrel, and what are his current coagulation profile?
Okay. Now his coagulation profile is normal, but he's taking aspirin and clopidogrel. So how you will prepare him for your anesthesia and surgery?
After discussing with the cardiologist, if permitted by the cardiologist, I would like to stop clopidogrel for at least 5 days before proceeding with any intervention.
And aspirin, how many days before?
Aspirin can be taken till the day of surgery.
Till the day of surgery. Clopidogrel is about 7 days. Anesthetists want it to be stopped about 7 days. Now, second thing is if cardiologist says he cannot stop, anticoagulants have to be continued, what will be the line of action?
I would like to switch the patient from long-term to short-term anticoagulants. I would like to shift the patient to heparin, then do a scopy, and then in the post-op period, start him again on long-term antiplatelet drugs.
So this is called bridge therapy, okay?
Okay, sir.
And you start low-dose molecular heparin, which you have to stop on the morning of the surgery.
Yes, sir.
So that's why I'm talking in general, because this formula applies to all the cases who are on blood thinner, whether you are taking for any endoscopic surgery or open surgery, you know. So these are the basic fundamentals should be known. Okay, go ahead. How you will like to plan for your cystoscopy? And now the question has been put to you, this role of multiparametric MRI. What is your comment on this?
So multiparametric MRI has recently been implemented, but is not been proven to be shown, has not been statistically proven to be effective in any treatment modality, although it can definitely tell between T1 and T2 lesions, but the still the gold standard is cystoscopy and biopsy.
Okay, Prabjot, you want to ask anything about this? Or
Sir, while describing the CT scan, Dr. Gagan, you should be telling about what are the lymph node status, especially the local lymph node as well as the retroperitoneal lymph nodes. They are very important. And the metastatic side, like lower cuts of the lungs as well as liver. Sir, what about the urine cytology? So you have told about the urine cytology. So echo was done, as sir said, you need a cardiac workup. Echo is suggestive of ejection fraction of 45%, and rest of the echo was normal. Cytology was positive for malignant cells, high grade malignant cell 3/3. So what is the cytology classification system you know?
We use Paris classification for urine cytology.
Can
What
you
is
enumerate
that?
In Paris classification, we usually classify cytology report into 6 categories. First is the adequacy of sample, then is low grade, atypical cells. Third is low grade. Fourth is suspicious for high grade. Fifth is high grade, and sixth is negative for high grade.
Can you tell that again?
Paris reporting criteria is used.
Yes.
The reporting is done in 6 points. First is first point, adequacy of the sample.
Yes.
Atypical cells.
No.
Third is
no.
Atypical.
Second is negative.
Okay. In that format, second is negative. Then third is suspicious for high grade malignancy.
Third is atypical.
Okay. Third is atypical. Then suspicious for high grade malignancy. then low grade malignancy, and 6 is high
No.
grade malignancy.
High grade is first, then low grade.
Okay.
Okay, so what's your plan now?
Sir, after getting fitness from anesthesia side, I would like to go for a transurethral biopsy of the patient.
Biopsy. What kind of biopsy are you planning?
TURBT, sir.
You want to do a TURBT. So say TURBT, why are you saying it biopsy? You plan to remove only a part of the tumor?
No, sir.
What's your plan?
I would like to remove the whole tumor, sir.
So call it TURBT.
TURBT, sir. Yes, sir.
What is the advantage of removing the total tumor instead of just doing a biopsy? Because you initially said, I will like to do biopsy only. Is there any advantage of doing a complete resection?
If the tumor comes out to be non-muscle invasive tumors, then it can be both diagnostic and therapeutic. Although this therapy will not be will be multimodality, but it can be. We will not have to proceed with TURBT in the next setting.
Yes. Number 2.
It gives a complete sample of if the sample
And
may be.
if turned out to be muscle invasive, then what is the advantage?
If multimodality treatment is planned, then also in muscle invasive tumors, it can be therapeutic.
So after your complete resection of the tumor, it will be, you are in a better position to do counseling of the patient, what kind of treatment. And if he is not a candidate for radical cystectomy and he goes for the bladder preservation protocol, then complete resection is better than doing incomplete resection.
Okay, sir.
Okay, we go to the next now.
So TURBT was done, complete resection, intra-urethra prostate bladder neck was normal. There was a large 6 centimeter papillary growth with overlying areas of calcification over the left posterior lateral wall, which was extending over the orifice, but it was not involving. And orifice could be seen after resection. The right orifice was normal. And there were 3 small, less than 1 centimeter papillary growths over the anterior wall as well as the right lateral wall. So what do you want to do? Anything you would like to do intraoperatively during surgery?
Yes, sir.
Patient has a tumor on the left side, lateral wall tumor. So anything you would like to do?
Apart from TURBT, I would like to take biopsies from the other tumors, and also I would like to take random biopsies and biopsy from the prostatic fossa.
Why do you want to do all this?
To do random biopsy in this case?
Sorry, sir, since there are multiple tumors, I would like to see the presence of any carcinoma in situ, and for prostatic, I would like to take a biopsy from the prostatic fossa.
Okay. Have you heard a terminology called ideal TURBT? This is given in your literature. So what is ideal TURBT?
Sorry, sir.
You know or you don't know?
No, sir.
I suggest you to go back to the literature and see what is ideal. This terminology has been coined, and I have questioned that terminology because in every case we like to do ideal TURBT, but this TURBT is basically a checklist. There are 8 or 9 points which you have to be very careful and do all those things whenever you are doing a TURBT. So you remember in every case what you have to do. Okay. So please go to the literature and read that ideal TURBT.
Okay, sir.
Any role of bimanual examination?
Yes, sir. Pre-op and post-op, I would like to do bimanual examination to know the completeness of TURBT.
How do you interpret the findings of your bimanual examination?
If the mass is palpable pre-operatively and in the post-op examination the mass is not palpable, then it usually suggests a complete TURBT and no involvement of perivesical tissue. If in the post-op we can palpate the tumor, then it usually suggests either incomplete TURBT or extravesical extension.
See, in the in the current era of all the investigations available like ultrasound and CT scan, See, when in our time in 70s, 80s, 90s, when there was no CT scan, the bimanual palpation was a very important factor, and every examiner will ask this question. But now I like ask to you this question in current scenario. What do you think is the advantage of bimanual examination? You do or don't do doesn't make any difference now. But in which situation it can help you? You got my question or no?
I got your question, yes, sir.
Okay.
In
So
doubtful
in
cases,
current, yes, you can. If you know, you answer. Otherwise, I'll answer.
sir, I'm not sure, sir.
Okay. So see, with this current investigations available, like in this particular case, you do or don't do is not going to make much difference. But certainly, if you are planning for a radical cystectomy operation, and if somebody has got a extra vesical extension, then bimanual examination will tell you whether it is fixed to the pelvic wall also or not. Actually, So, or a post-radiation cases also. So there you will know that what kind of difficulty you are going to come across in the surgery, and that will also help you whether to operate or not to operate in this case. Next.
Dr. Gagan, would it be an easy TURBT or a difficult TURBT?
Sir, since there are multiple tumors, I don't, since it's a large tumor, it will be difficult TURBT.
Anything extra would you like to do? What is the main problem with lateral wall tumors, large lateral wall tumors, resecting them?
Obturator block or general anesthesia because of obturator.
What difficulty would you anticipate when you are resecting a large tumor on the lateral wall, posterolateral wall?
Obturator jerk, number one, and second in nearness to the ureteric orifice. I think two.
Any possibility of obturator jerk?
Yes, obturator jerk and nearness to orifice. These two difficulties can be encountered.
How do you manage obturator reflex?
Either we can give an operation or keep the patient under general anesthesia with muscle relaxation.
Okay, what about the second point which Dr. Prabhajot has highlighted? En bloc versus piecemeal resection?
So, en bloc resection has an advantage of giving a complete tumor for histopathological examinations. Although it is also proposed that en bloc leads to less implantation, but it has not yet been. So the one advantage that we get complete histopathological examination of the tumor and higher chances of getting muscle sample.
And what would be your preferred modality of energy for en bloc? Laser or electrocautery?
We usually do en bloc with electrocautery.
Okay, I think let's move forward.
What is the relation of if you are using laser and obturator block is needed or not?
No, sir. Obturator block is not needed if we are using laser.
Another thing, you have reached to this stage. Have you heard about urinary tumor markers?
Yes, sir. Yes, sir. We have. Yes, sir.
Would you consider anyone in this, because you are going for without biopsy, you are going for TURBT?
Sir, in the current scenario, we usually do not use any available tumor markers because they don't have very high sensitivity plus specificity. None of them can replace transurethral TURBT.
Okay, so we can change now to next candidate. Dr. Devendra can join in now. Please put your audio visual on, Dr. Devendra.
Yes, sir.
Yeah, okay.
Good evening, teachers.
Evening.
So Dr. Devendra, so surgery has been done. What you will do post-operatively, immediately post-operatively, this patient?
Sir, in immediate post-op period, if there is no hematuria, we can give intravesical mitomycin, sir, within 24 hours.
Suppose during TURBT there was an obturator jerk and there was a little bit of perforation in the bladder.
Yes, sir.
Would you still go ahead and give a intravesical mitomycin?
No, sir. We should avoid mitomycin if there is a perforation or there is any incomplete tumors.
And what is the ideal time when you should give this intravesical mitomycin?
Sir, ideally within 6 hours, but we can give intravesical mitomycin up to 24 hours. As soon as the hematuria is clear.
And why do you want to give it preferably within 6 hours? What is the rationale?
Sir, to decrease the chances of tumor implantation.
What will happen between 6 to 24 hours that will not help?
Sorry, sir.
There would be a formation of some extracellular matrix layer over your resected area.
Okay.
So the drug may not act. So the sooner you give it, the better it is, ideally within 6 hours.
Yes.
You have told that in perforation you don't give mitomycin, and in incomplete resection also you don't give. What is the reason?
Yes, sir. Sir, in incomplete resection, there will be no role of mitomycin, as mitomycin act on the base of the bladder and decrease the chances of tumor implantation if some cells are remaining.
So tumor cells are reimplanted at the base only?
No, sir. Whole of the bladder. There are chances of implantation at the fundus, maximum chances are at the fundus.
So why you are saying that it will be on the base, and if there is a incomplete, because you don't know, in a relook only after 2 weeks you will come to know whether the residual tumor was there or not. So if you after in relook surgery you find tumor, that means you have taken wrong decision at that time by giving mitomycin. Perforation, I agree. That is absolute contraindication. There has to be some logic, na, for this.
Yes, sir.
Because nowadays the trials are going on even before TURBT. They are giving mitomycin. Some trials are going on when the whole tumor is intact. Anyway, continue.
So once you have sent the tissue for biopsy, what you are going to look at the histopathology report?
So type of tumor, the grade of the tumor, lymphovascular invasion, and
yes,
positive. Yes, sir.
Hello, can you hear me?
Yes, sir.
Yes, sir, we can hear you.
Yes, sir.
Type of tumor, what else?
Type of tumor, grade of the tumor, lymphovascular invasion.
Yes.
And muscle invasion, sir, deep muscle invasion.
Yes. Or
And,
any other changes in the, if other biopsies are taken, what are the changes?
Carcinoma, presence of carcinoma in situ, sir.
Yeah. So, Prabjot, you can take over.
Yeah, that was I wanted to ask you, any variants, histological variants?
Plasmacytoid variants are micropapillary and sarcomatoid variants, sir.
I mean, there are only 3 variants. Is that what you're saying?
No, sir, there are other also, but I'm not remembering, sir.
Yeah, but why you mentioned these 3? These 3 are more important than others.
Yes, sir. Yes, sir.
Because they carry a much poorer prognosis.
Yes.
There are other variants, nested variants, and so on. Okay, so this is the biopsy report. What next?
So it's a high-grade T1 tumor and non-muscle invasive. So I want to give intravesical BCG to him, sir, SWOG regime, after 2 to 3 weeks, sir. of TURBT.
Have you heard of relook TURBT?
Yes, sir.
And what, according to you, would be the indications
Relook
for doing a
TURBT.
relook TURBT?
Yes, sir. Relook TURBT, sir, high-grade T1 tumor, lymphovascular invasion, and incompletely resected tumor. We should do relook TURBT, sir. So I have to
And
do.
One more indication is there. If the muscle is not included.
Yes, sir. If muscle is not included.
So in this patient, would you consider doing a relook TURBT?
Yes, sir. Relook TURBT I should do.
Why you want to do relook TURBT? Because the report is showing straightforward.
Sir, it's a high-grade tumor, and tumor stage is changed in relook TURBT in 30 to 40% cases, sir. So I want to do re-TURBT, restaging.
So according
TURBT.
to you, in all cases, relook TURBT has to be done.
Yes, sir. In high-risk cases, in all high-risk cases, we should do re-TURBT.
Because some surgeons, I'm just for the sake of discussion mentioning this to you, some surgeon thinks that if they have done themselves the TURBT and they are confident that I can do a good job, then they say there is no need for TURBT, why you are wasting your time. So what is your comment on that? Is that right practice or wrong practice?
Sir, re-TURBT is recommended, so we should do. It is written in our textbook, sir.
Okay, that's good. So you should follow your textbooks.
Yes, sir.
So this is the report of.
After 4
yeah,
weeks.
probably. Go ahead.
Yeah, restage was done after 4 weeks, and intraoperatively there was unhealthy scar area, but no obvious tumor. Biopsy was taken from the deep muscle, and the biopsy came as T1 G3.
Yes, sir.
No obvious tumor, and deep muscle was free.
Yes, sir. It is stage T1, sir. So we should do stage for staging. CT scan already done. There was no lymph node, and the chest X-ray was clear. So the stage would be T1 N0 M0, sir.
So high grade, low grade.
It's a high grade.
So in which
you
category?
Consider doing risk stratification?
Yes, sir. Risk stratification is it's a high risk tumor, sir. It's because grade is G3, sir.
Are there any subgroups in the high risk category?
It's the highest risk in this high risk group, sir.
So where does this patient fit in the highest risk?
Yes, sir.
And can you just tell what are the
in highest risk, sir, a large tumor grade G3 G4 and with our lymphovascular invasion and involvement of ureteric orifice.
So what
these are the highest risk, sir.
That would
how you will do the counseling to the patient, because patient has come back to you, this is the biopsy report final, and now you have to do counseling of the patient. How you will explain to him?
I will counsel him that I will counsel him that it's a high grade tumor and the TURBT is not sufficient. The treatment is long, and he should follow up frequently as advised to him, and multiple times, and he will be given intravesical BCG also, sir. And after BCG, he may have a recurrence. So treatment is very long.
What about the early cystectomy? Why can't you advise that to this patient?
Early cystectomy is advisable in this highest risk group, sir. I will also counsel him for early cystectomy and tell him the benefits of the early cystectomy, and also I will tell him the complications of the cystectomy.
So final decision will be yours or patient?
Patient, sir. If patient is ready for the early cystectomy, I will proceed with the early cystectomy.
In view of the comorbid conditions of cardiac and also echo is 45%.
Yes, sir. Yes, sir.
You will upfront recommend early cystectomy in this case?
Sir, I will tell him the
73 years of age.
Yes, sir. I will tell him the all the high risk of the surgery and also the comorbidities. If
So he says that I leave it to you. You decide now because both are feasible. Now, what is your decision?
sir, I will avoid surgery, sir. I will proceed with intravesical BCG.
Right. Okay. So,
Patient
what are
started
the
already. Sorry.
intravesical BCG you start immediately or you wait for the
2 weeks.
jack cystoscopy and after that you start?
No, sir. After re-TURBT, we have to wait for minimum 2 weeks. Then we have to start intravesical BCG.
Okay. Okay.
Which regime of BCG would you give?
Sir, I will prefer SWOG regime, sir.
What is that?
Sir, induction dose is 6 cycles of intravesical BCG, 80 milligram weekly. Then maintenance dose is 3 monthly for 6 months. Then 6 monthly for 1 year and 6 monthly for next 3 years. Sir.
What
And
are the other regimes?
LAM regime, sir. Monthly regime. Yes, sir. Monthly
LAM regime, how it is given?
Sir, it is given monthly intravesical BCG.
No, right from the beginning you start monthly?
No, sir. After induction. In maintenance, it is given monthly.
It is given monthly. You give after 3 months, again 3 doses. And after again 3 months, again 3 doses weekly. That is LAM regime.
Yes.
And why not mitomycin?
No, one thing more before that. Why you have chosen 80 milligram? Why not 120 milligram, the standard dose?
Sir, in Indian population, 120 milligram and 80 milligram, they have same efficacy, but 120 milligram dose has higher side effects. So the consensus is on the 80 milligram dose in Indian population.
But in Western, even the recent literature from Europe, they are recommending 120 milligram, which is more effective. Is it right or wrong? I don't know.
Sir, efficacy is same, 80 milligram, 120 milligrams.
Actually, there was another strain in India where we were giving 120. And then came onco-BCG. And in onco-BCG, a study was done by Serum Institute. And that was accepted. And that is 120 and 80 milligram, the efficacy is same. That you are right. But that was for the different strains.
Yes.
By any chance, you remember which one was the old strain?
I didn't get, sir. Pardon.
There was a strain used in India earlier to onco BCG. Which strain was that? BCG?
So Danish 1331 is the
Danish strain. Yeah.
Yes.
So that was 120 only.
Yes.
So the dose for that was 120 only. The new strain which had come and used by Serum Institute, onco BCG, there it is 80 and 120 had shown the equal
Similar
efficacy.
Yes.
Okay. So now the next question was, why not mitomycin C?
Mitomycin C has, sir, sir, BCG decreases the recurrence and also the progression. But mitomycin C only decreases recurrence, not progression. So BCG is preferred.
So intravesical immunotherapy, that gives, that is the basically immunotherapy, BCG, and mitomycin is chemotherapy. Intravesical chemotherapy is not benefiting in progression.
Yes, sir.
And interferons are very costly. So we are using BCG.
Intravesical.
And what is happening, just for a point, that what is happening in the view of global shortage of BCG? We are using now mitomycin C
Yes, sir.
in a new way.
HIVEC, sir. Hyperthermic intravesical
Yeah,
chemotherapy.
that is giving, that is supposed to be reported as giving equivalent results.
Yes, sir.
Okay.
The patient was started on intravesical BCG. He received induction 6 doses and the 3 doses of first maintenance. And cystoscopy at 3 months was showing free erythematous area, query BCG changes.
Yes, sir.
We have already discussed
So
different
which
regimes.
regime is this?
It is, sir, SWOG regime.
6 doses of induction, and after that 3 doses of first maintenance.
3 months.
3 weekly doses are in a LAM regime.
Yes, sir. LAM regime.
Okay.
But the patient started having low tract symptoms, mainly storage symptoms.
For storage symptoms, we can give him anticholinergics, or we can start him on beta-3 agonists, mirabackground, and they may be due to BCG. So we can hold 1 or 2 cycle of BCG and see that if it is due to BCG or not. If it is due to BCG, then we can stop for some time, then restart the cycle. Sir.
In BCG related intolerance, you are saying that we can stop and restart.
Yes, sir. 1 or 2
you are
cycles.
suspecting that.
Yes, sir. We may skip.
And again, if patient is having same symptoms,
then we should start him on anti-BCG treatment, sir.
What is that?
Sir, isoniazid. Initially isoniazid. If it is not controlled with isoniazid, then we should give isoniazid with rifampicin.
So now it is not getting controlled. What you will do? Still patient is having intolerance.
Then, sir, we can counsel the patient that is BCG intolerant. So we can give gemcitabine or mitomycin and hyperthermic intravesical chemotherapy.
So these are the options.
Yes, sir.
Okay, you tell me what are the first line therapies. One is BCG, we have discussed. If
Yes,
there is contraindication, we give mitomycin. Anything else is in first line in any guidelines?
So systemic pembrolizumab can be given, sir. Systemic pembrolizumab.
Along with intravesical therapy.
Intravesical
Not
gemcitabine.
alone.
Yes, sir.
Not alone. That is
Yes.
one, but cheaper one, you tell.
Sir, I think we finished with the first.
Gemcitabine has been put in first line also. In which guidelines?
Okay, Prabjot, you can summarize now.
So it is in NCCN guidelines. If
Yes.
BCG is not available, either a HIVEC, or if that is also not available, then gemcitabine is in the first line.
Okay.
So thank you, teachers, and thank you, resident. So I'm going to talk about 4-5 slides about recent updates which happened in the last few years in non-muscle invasive bladder cancer. As Dr. Gagan very well mentioned about the Paris Working Group standardization of the reporting system of urine cytology. So in examiner can ask you. So you should go and read what are the classification. The 6th classification and 7th is about variant histology. Now, like in the prostate cancer, we have a pirate scoring system. Now in bladder, it is coming up with a big way, like a virate scoring system, which is vesical imaging reporting and data system. which includes the T2 weighted images, diffusion weighted, as well as contrast enhanced images. And basically the advantage of this imaging is you can diagnose pre-operatively that is muscle invasive disease or not. So in EAU guidelines, we used to have, there are some changes in this year as compared to the 2020. And initially we used to have T1 tumor, whether it's low grade, high grade, included in the high risk group. Now in 2021, they have included in the low risk group if it is low grade. T1 low grade is included into the low risk group if it is less than 3 centimeters. This is a major change they have done. I don't know what is the logic behind that. And for a very high risk tumor, they added the 3 additional risk factors. If the age is more than 70 years, multiple papillary tumor, and tumor's diameter is more than 3 centimeters, so it can be included with T1 G3 tumor. They can be included into the very high risk. So resident has to go back and read all these guidelines properly. So regarding the restage TURBT, the indications are T1 tumor, yes. And after incomplete TURBT or the patient who have been referred from outside and they're saying the complete TURBT has been done, as the Dr. Gupta suggested, that you have not done you are not so confident that you have done the complete resection, restage is indicated, or there is no detrusor muscle included in the specimen except for the low grade tumors. And the advantage is upstaging of the tumor, and it has been also said that it improves the progression-free survival and recurrence-free if the no muscle was included in the first resection. So EAU also has done the risk stratification. Low risk tumors, we can give the 1 dose of intravesical chemotherapy, and intermediate we can give the 1 year of BCG or mitomycin depending upon the individual patient risk factors. And the high risk group we can give intravesical BCG or the cystectomy, or in the very high risk group we can offer the patient the radical cystectomy depending upon the patient's comorbidities. And there are 2 scoring systems are also available, which you should be knowing: ERTC scoring system and Kyoto risk scoring system for the to predict the recurrence-free as well as progression-free survival in the patient on BCG. So we missed actually slides because time was getting over. So now there is a new definition which came 2 years back: BCG unresponsive tumor, which means the patient is having like BCG refractory tumor who developed the T1 G3 recurrence within 6 months of completion of adequate BCG. Then what is adequate BCG? Adequate BCG is at least 5 to 6 doses of initial induction courses and the maintenance dose of 2 out of 3. So this definition is very, very important. And the treatment is cystectomy, or the patient, if wants the bladder preservation protocol, that can be put under the trials. So this slide I've taken from the plenary session of conference 2022-20, and they given the names of the cystectomy depending on at what time you do. If you are doing upfront surgery with the very high risk patient, you can call it as immediate or early cystectomy. If there is a BCG failure patients, you can call it as late cystectomy, and too late cystectomy if it is already muscle invasive tumors. So all the best to everybody. Thank you very much.
So thank you very much, Dr. Prabhjot, for excellent moderation, and also thanks all the residents who showed the guts to face all the 3 esteemed teachers. And now we move to the next case, and Dr. Himanshu Pandey is going to moderate this case. So over to Dr. Himanshu, please share your slides, and Dr. Abhishek will start the Viva for this second case. So Dr. You can now share your slides. And there was a request that we can summarize that what all mistakes our residents have done during their Viva. So maybe Prabhjot and Dr. Himanshu, they can, in the last of this session, can just summarize 2-3 points for those residents who have taken the Viva, just to guide them. So now, Dr. Himanshu, you can start this first slide. And over to our teachers again.
Good evening, sir. Good evening, our respected expert panel, Dr. NP Gupta, sir, Dr. Sood, sir, and Dr. Samir Trivedi, sir. And I'll be starting the case number 2, and all the very best for the to the students. So the case is she's a 45-year-old female with a resident of Bulandshahr, Uttar Pradesh, and she is housewife, and she presented to the OPD with presenting complaints of left flank pain for last 2 years. What next? How will you proceed?
Hello, sir. Hello, am I audible, sir?
Yeah, Abhishek, you are audible.
Good evening, sir. Myself, Dr. Abhishek, second year resident, sir. Sir, my first question to the patient would be the type of pain, whether the pain is radiating or not, and is it associated with any hematuria? If it is associated with hematuria, is there any passage of clots and the form of clots? Like whether it is a thread or worm-like clots which she is passing, or whether there are other types of clots. And I would like to also ask for any history of graveluria, pyuria, and also whether the pain is dull aching or colicky in nature would be, and are there any postural variation to the pain, and whether she is on any medications to relieve the pain.
So,
Hello. Can you
Hello.
interrupt? Hello.
Yes, sir.
Hello.
You're audible.
No, will you like to ask the lower urinary tract symptoms also or no?
Yes, sir. I would like to ask the lower urinary tract symptoms as well in the patient, sir.
And any history of fever or
Yes, history of fever will also be included in the history, sir. Yes. Sir.
Okay.
Should I proceed to next slide?
Yes,
Sir?
yes, go ahead.
Yes. Image.
So, as Dr. Abhishek asked, the pain was for 2 years off and on, and with a frequency of once or twice in once or twice in 2 months, and she used to take painkillers to subside the pain. Last episode she experienced was 15 days ago. It was acute colicky in nature, intermittent and non-radiating. It was occasionally associated with nausea and vomiting, for which she was not taking any medication. There were no as such aggravating factors she can recall, and it was relieved by analgesics, simple analgesics. There is a history of occasional dysuria only, but no history of fever or pyuria, no history of any specific lower tract symptoms, no history of lichuria or graveluria. There is no history of any trauma to the abdomen or to the pelvis, no history with, of the tuberculosis, either affected by tuberculosis herself or in contact with the tuberculosis. And she was not also having any history of acute urinary retention or catheterization and any sort of instrumentation. So, past history, she's a known diabetic on oral hypoglycemic for 7 years with poor compliance, and recently diagnosed with hypertension, and she's on antihypertensive drugs, and the hypertension is bed controlled. And no history of tuberculosis or COPD or asthma, no history of any previous surgery. So, personal history, she's married and having 2 kids, all full-term normal vaginal delivery with regular menstrual cycles. Last menstrual period were on the 1st March 2021. No addiction, vegetarian by diet, and she claims to be having water intake of 2 liters per day, and family history is nothing much significant to deal with. So this is all about history. Anything else?
What is the what is the thinking in the mind? What diagnosis comes in your mind?
Sir, I had listed 3 differential diagnoses. One would be, first would be a case of a renal stone disease. Second, I'm suspecting it to be a POGO. Third would be my infective etiology. Since she's a diabetic, so some form of pyelonephritis can also be one of my differential diagnoses.
But
whenever you give these differential diagnoses, you are giving a sequence. You started with a stone disease. So will you tell me how do you justify this sequence, what you have given? 1, 2, 3.
Sir, the nature of pain, it is acute, intermittent and colicky.
No.
Associated with...
Listen 1 minute here. Yes, you gave 3 differential diagnoses, keeping in your mind the presenting history of this patient. So you think by just type of pain, you will differentiate between 1 and 2 and 2 and 3. No.
No,
so
sir.
You have to be very careful when you answer this question. If you don't know, we will answer you that.
Yes.
What?
Just by
Can
the
you
pain.
Justify why you want to put stone disease as number 1?
Sir, acute colicky with episodes of nausea and vomiting would be stone disease, sir. And most commonly, we encounter stone diseases more commonly in our OPDS with flank pain, sir. So what may one of my
that is a more right answer.
Yes, sir.
Because whenever you give the provisional diagnosis 1, 2, 3, the
Yes,
most
sir.
common thing you should give first. And
Yes, sir.
I'm sure in your OPD, as you have mentioned now, that
Yes,
you see more cases of stone disease in comparison to PUJ.
Yes, sir.
UTI, you know, already I have asked that question. So there are no
Yes, sir.
symptoms of UTI. So
Yes,
that's
sir.
why you can put as number 3. But
Yes.
that sequence is according to that. This I am
Yes.
answering you just to tell all the postgraduates that when you give your provisional diagnosis and when you put the sequence 1, 2, 3, you should be very careful because
Yes,
immediately
sir.
exam asks you this question.
Yes, sir.
Okay, go ahead.
So to summarize the history in a nutshell, she's a 45 years old female with diabetes that is uncontrolled, hypertension controlled on a single medication with acute intermittent non-radiating colicky pain for 2 years, with occasional dysuria without any fever, hematuria, or lower intake symptoms, and without any prior surgical intervention. So what next would you like to go ahead?
Sir, I would like to examine the patient with a general physical examination. Look for any pallor or generalized lymphadenopathy along with pedal edema. And subsequently, I will do a physical examination, systemic examination, in which I would like to rule out any renal angle tenderness or renal angle fullness would be my examination. Then I will move on to investigation part, sir. I would like to get a hemogram with a differential counts and TLC. I would like to get a urine routine microscopy and urine culture along with coagulation profile and basic investigations of coagulogram, sir. Following that, I would like to get an ultrasound done for the patient, which includes USG, kidney, abdomen, kidney, ureters, and bladder, sir. And also to get an X-ray chest and X-ray KUB, sir, prior to getting an ultrasound for the patient.
Why do you want a coagulation profile?
Sir, if in case I am planning to operate this patient, so that would be just a precautionary investigation, nothing to do with the disease process as such, sir.
Isn't that jumping the gun? That investigation may turn out to be totally unnecessary before you have reached a diagnosis. That can always be done prior to any intervention.
Yes, sir. Yes, sir.
Because then you would end up getting it done for all your patients who come to your OPDs.
Yes, sir. Yes. Okay,
sir. So choose your investigations wisely. Right now, as sir has pointed out earlier, your investigation should be tailored towards making a diagnosis, not towards management. That will start once you have reached a diagnosis.
Okay.
Similarly, chest X-ray right now, it doesn't make sense to me. Why do you want a chest X-ray?
So in the next slide, please.
Okay, so general physical examination is general physical examination was essentially normal with the pulse rate of 93 with the BP of 146/94, her abdomen normal, genitalia normal, no postvertebral angle tenderness.
So in the next slide also, because you already
so diagnosis, as he has already Dr. Abhishek has already told that renal stone disease, UPJ, cystic disease, or GUTB. Next, the investigations which were done.
Just hold on. Go back one slide.
Sure.
Now, Abhishek, he has mentioned GUTB, and you have mentioned chronic UTI or pyelonephritis. So you agree with this GUTB or no?
Sir, in India, GUTB is quite, tuberculosis is quite prevalent, sir. So GUTB can be one of the differential diagnosis that we can keep here. But although she does not give any contact history, no history of tuberculosis.
No, but there are no lower urine tract symptoms at all in this patient.
Yes, sir. Also,
so why you
LUTS
have
is
to
not.
put GUTB, you know?
Yes, sir.
It's very unusual. Without lower tract, you will have a GUTB like this. No?
Yes, sir. But the patient is a diabetic, so I would like to give pyelonephritis more common.
Yeah, that we agree with you. Next.
Yes,
so next, sir, urinary investigations were done. Blood investigation was serum creatinine with 3.2 electrolytes within normal limit. Her random blood sugar was 280 milligram per deciliter with HbA1c 10.2. CBC were within normal limit, and urinary examination routine or pH 6.3, specific gravity 1.012 with protein +2 in the urine, RBC 0 to 1 per high power field with 8 to 10 WBCs per high power field, and culture was done and no growth steroid.
So Abhishek.
Yes, sir.
Now the next question is imaging. You have already mentioned plain X-ray, ultrasound. You have not mentioned CT scan, but somebody will mention that also. How you choose a investigation in such kind of scenario? when there is abdominal pain is there.
Sir, in this case, sir, I did not know the RFT values. So simply jumping onto CT would be more.
So now you have got RFT also, so don't drop that.
Yes, sir.
RFT
So with
3.2 creatinine.
3.2 creatinine with an RFT and patient is having a unilateral pain, sir. So getting a non-contrast CT would be useful just to rule out a stone disease, but we not be able to assess the parenchymal, the functional status of the kidney or whether the kidney is enhancing or not. And although if I wanted to see any hydronephrosis and all, for that ultrasound would be sufficient, and that can also determine whether there is parenchymal present, although less sensitive compared to CT. But with this high creatinine, only NCCT KUB can be done in this patient, sir, right now.
Why not ultrasound first?
Sir, ultrasound should be done first, and following ultrasound and NCCT KUB can also be determined to rule out any stone disease and also to ascertain whether the parenchymal thickness is good or not.
That ultrasound will tell you. Anyway, go ahead. Next.
So ultrasound was done, and
Dr. Himanshu, I think we can shift to the next candidate. Dr. Amitabh will take over. You can put your audio visual on, and now you can take over.
So good evening, Dr. Amitabh, and
yes, good evening. Good evening,
proceeding. Sir. Okay, so proceed. So carrying on the proceedings, ultrasound was done. These are the ultrasound films. These are the two ultrasound films. If you want,
yes,
I would roll it again.
Yes, sir. In the films that is shown in the right side, the right corner, hyperechoic foci is seen in the lower pole of the right kidney, probably right kidney because left kidney is marked. So, but I cannot see a posterior caustic shadowing in this. So maybe a calcification, and there is no hydronephrosis. Parenchymal thickness appears normal, and this echogenicity is also normal on the right side. Left side kidney, there is a hyperechoic region seen in the kidney with posterior acoustic shadowing is seen. So probably this is a stone, most likely. And parenchymal thickness appears normal, and corticomedullary differentiation and parenchymal echogenicity appears normal. So I cannot make out hydronephrosis in this because it seems that the whole of the pelvic calyceal system is occupied by the stones.
And again, the next another slide of the bladder ultrasound.
Yes, in the bladder films given, that is the transverse film, the bladder wall thickness appears normal. I cannot make out any hyperechoic or hypoechoic focus in the bladder, and the wall thickness appears normal in this.
Should we proceed, or any questions from the expert panel?
Only one thing, he can see the size of the bladder is also normal.
Yes, sir.
So that helps you to exclude a GUTV business, you know, what has been mentioned.
Yes, sir.
Okay, go ahead.
So what next would you like to do, Dr. Amitabh?
So since the patient has presented with a creatinine value that is 3.2, so actually to further investigate about the stone disease, I need a further imaging because I have to plan surgery according to that. So NCCT scan will be ideal for this patient because we cannot do a contrast study. So I'll ask NCCT scan. Next, sir.
So is it possible to do an MRI in this?
No, sir. MRI has not got a good sensitivity for stone disease, so I'll not go with MRI, sir.
Any other drawback of MRI?
Drawback. One thing is the acquisition time is long, so the patient with claustrophobia.
Can you use gadolinium in this?
Gadolinium with 3.2, sir. I first have to calculate EGFR. If the EGFR is less than 30, so I cannot use gadolinium also, sir, most likely, because that will lead to NSF, sir, nephrogenic systemic fibrosis.
Read the CT.
Okay, the NCCT KV was done. There are a few slides of NCCT KV. First, let me run those slides and then read it, and I'll scroll it again for you. This is the first slide, second slide, third one, that is the, and this is the coronal reconstruction, and this is the 3D reconstruction. So to start with the first slide, this is the first slide. This is the first slide.
Yes, in the first slide. Yes, in the first slide, on the left side of the kidney, there is a hyperdense foci that is seen in the left side. probably in the upper polar calyx. So that is most likely a stone. Coming to the next slide, also I can see that same hypotenuse focus extending downwards. Right side kidney appears normal here, and then this hypotenuse foci keeps continuing. This is the pelvic calyceal system in which it is extending, and then also in the calyx. So it seems that yes, sir. So this is seems to occupying the pelvis, upper calyx, and the pelvis, upper calyx, middle calyx, and I'm not able to see the lower calyx image. So probably if I see the sagittal section, I'll be. So it is occupying the lower calyx also. And on the right side, I can see a small hypotenuse foci, that is calculus, on the inferior calyx of the right kidney.
This is 3D reconstruction. Can you
Yes,
say anything about this 3D reconstruction?
yes, sir. In the 3D reconstruction, I can see that there is a small calculus in the right kidney, and on the left side, it's the pelvic calyceal system, the pelvis, upper calyx, lower calyx, and all everything is occupied. So it is a staghorn calculus, complete staghorn calculus, sir.
Okay, so the report was left renal staghorn calculus with right-sided 5 mm inferior calyceal calculus. So what next?
Any other information which you would like to have from the CT scan?
From the CT scans, sir, with so I would have liked to see the distal passage of the contrast, but since this is non-contrast
It's a
study, I cannot.
non-contrast.
Yes, sir, I cannot make out any further.
What treatment are you planning for this stone?
No.
Sir, for such a large stone, sir, it will be a staged procedure. I'll plan for a PCNL. So
if you're planning a PCNL, what information do you want from a CT scan?
Sir, I'd like to know the anatomy of the calyces, sir.
Yes, that you have got. What else?
And parenchymal thickness also.
Have you heard of scoring systems?
Yes, sir. Scoring system. Yes, sir. PCNL scoring system, that is a stone burden that we calculate. A guy's stone score is there. And
so what are the things that you look for when you calculate a score, which tell you about the likely difficulty or in a PCNL?
Sir, we first thing is know the size of the stone, then Hounsfield unit of the stone, then
Hounsfield unit you would like to know? Yes.
Yes, yes,
what
sir.
Else?
Then if there is any anatomical aberrations are there, like diverticula or anything, so because and total burden of the stone.
There are a couple of other things. What is the skin to stone distance?
Yes, sir.
What is the number of likely punctures that you would like to do? Whether there is any intervening viscera in the line of your puncture, whether the liver or colon, anything is coming in between your planned puncture and the kidney. All those things, that's why you got a CT scan done, otherwise the plain X-ray would have sufficed.
Yes, sir.
Okay. So what do you want to do now?
What next? So this is the report of the CT scan with the left renal staghorn calculus with right-sided 5 mm calculus in the inferior calyx.
Sir, I would like to see the differential function of the kidney, sir. How much kidney is functioning on the left side and how much on the right side, because I can counsel the patient better, because for such a large stone, if I am doing a PCNL, the loss of parenchyma will be more, and patient with poor functioning kidney can have loss of function also. So for documentation purpose, I like to do a differential scan for function of the kidneys first.
So the renal scan was done non-obstructive drainage with a differential of 40% on the left side and 60% on the right side. What next?
So, sir, after this, sir, I will plan this patient for surgery.
Can you go back to that slide?
Yes, sir.
Yeah, just for me, sir.
Now she has a GFR of 100 ml.
Yes,
sir. Somehow actually we are also surprised, but I don't think this is right.
Okay.
No, I like to, hello, can
Yes,
you
sir.
hear me?
Yes, sir.
No, I like to point out what they have mentioned here is differential function. So this is the relative function between the two kidneys. It is not the
No, sir.
GFR.
No, sir, the
Please check.
second line,
No,
41
Yes, sir.
ml per minute.
And this
no,
59.
no, that's why I'm saying please check that carefully. You have to go back to your nuclear medicine physicist and ask him whether this is the GFR or not. Because
Sir,
with a
actually,
100 GFR, to have is 3.2 creatinine is difficult to explain.
Yes.
this DTP actually was done outside the hospital, so we didn't repeat it because somehow
Okay,
the
it's all
patient
right.
was
No.
not followed. So,
Does it going to make any difference in the management now?
Yes.
After
Yes,
seeing this report of the scan?
No, sir. In the management is not going to make much of the difference, but for counseling purpose, I had got this DTP scan done because
Now, which side you will like to operate first? You want to take out the right kidney stone or you want to take out the left kidney stone?
No, sir. Right side kidney, it is just a 5 mm calculus, non-obstructing. There's no hydronephrosis. There is no need to tackle that kidney first. I'll go with the left kidney first, sir. I'll remove this tag on.
And suppose during your surgery there is a complication, and you will lose this left kidney. Then she will have a single functioning kidney
with a stone.
So what is the rule of thumb for in bilateral disease? Which side should be done first?
Sir, in bilateral disease, if the kidney function test is normal, sir, and the creatinine is
equal, you can say, not normal, equal.
Yes, sir. If it is equal, then we have to tackle the poorly functioning kidney first. But if there is deterioration of the renal function, then better functioning kidney has to be preserved first, and then we have to do for the poorly functioning.
Yeah, that is one. What is
But
second?
renal functions with this kind of scan report, are we sure what is the renal function?
No, Raju, we have already discussed that. Suppose this report is correct, so we are talking on that line. What is the second rule? That is the first rule you have said.
Yes, sir. Then, sorry, sir.
Next rule. No, there's also one rule more is there, that in case of equal function or different functions, if you are contemplating that while you are doing surgery, there can be a complication or there may be a removal of the kidney. In that situation, you have to operate the better functioning kidney first. So at least your one kidney is preserved, then you can go ahead with the other kidney. But provided patient does not have pain or symptoms, provided patient does not have infection. Can you hear me?
Yes, sir.
So there was some interruption in my here. Okay.
Okay, sir. Should I proceed?
Yeah. Go ahead.
So, sir, the final diagnosis, Dr. Amitabh, final diagnosis with we were left was CKD with left renal stagnant calculus with a small non-obstructing 5 mm inferior calycial calculus on the right side with hypertension and uncontrolled diabetes, mellitus type 2. What do you want to do next? And indications of the treatment. What do you want to do with the patient?
Sir, this patient requires surgery, but at present her HbA1c level was very high. It was 10.6. So my first priority will be to control her blood sugar levels. Then I'll prioritize my treatment and I'll counsel the patient for a staged PCNL procedure for the left side. Sir.
Will you like to do metabolic workup now or you want to do it later on?
No, sir. Metabolic workup is done only after clearance of the stone because in the presence of stone, metabolic workup is not going to be much help because the stone can secrete X amount of minerals, and so it will not give us exact idea, sir. So after
How do you
clearance
know? Will you like to do at least PTA test if you don't want to do urine? Suppose she has a hyperparathyroidism, then.
Yes, a complete metabolic evaluation is not done, but in abbreviated protocol, we have investigation like intact parathyroid hormone, calcium, then uric acid, and then blood gas analysis, and calcium, sodium, potassium. So these are abbreviated protocol. But in patients requiring complete metabolic evaluation, we do only after complete stone clearance, sir.
So first, the basic test you will do in all cases.
Yes, sir.
Yeah. Okay.
So, sir, we counseled regarding all that these metabolic workup and evaluation and the timing, and the patient agreed. Patient asked that she would undergo metabolic evaluation after only the surgery is done. So next, as Dr. Amitabh said, PSC workup was done. Endocrinologist opinion, cardiologist opinion were taken. Patient, after getting her blood sugar controlled, patient was deemed fit for surgery. So, what are the indications of the surgery in a case of renal calculus?
Surgery indication for surgery is are patient having symptoms, patient having loss of function because of the stone, then patient cannot be managed with conservative maneuvers like based on the stone size. Actually, we decide whether the surgery is required or not. So patient has, for stone disease management, we have option of ESWL, we have option of and endoscopic surgeries also. So ESWL is indicated in those patients with a CT stone hardness is low, that is probably CT value of Hounsfield unit of less than 900, and then stone size various at various places have been described. So stone in the pelvic calyceal system, pelvis is 2 centimeter up to 2 centimeter. We can operate in the lower calyx up to 1.5 centimeter. In the other calyxes up to 2 centimeter, we can go for ESWL. But more than this size, we have options of PCNL. So indication for surgery is pain and loss of function, sir, in this patient, sir.
Now, Amitabh, patient
Yes,
relative is sitting with the patient and they are asking you one question.
Yes,
now
sir.
her creatinine is 3.2. Doctor, what is your expectation? This creatinine will come back to the normal or not? How you will counsel that?
No, sir, I'll counsel the patient that the creatine may not come back to the normal levels because the left side kidney might have been damaged by the long-standing nature of the disease and the complete occupancy of the pelvic calyceal system by the stone. So I'll counsel the patient that the creatine may not come back to the normal level. Also, I'll counsel the patient about the need for post-operative dialysis and in the intraoperative more blood loss because of the platelet dysfunction. So during my counseling, I'll give emphasis on these points. Also, I'll explain the patient that the one sitting of the surgery may not do the complete clearance of the stone, and patient may require multiple sittings and multiple punctures may be required. So after all these things only, I'll take the patient for surgeries.
Okay, good. That counseling is very important, what you mentioned. And complications of the surgery should also be told to them.
Yes.
So I would like
Next.
to add one thing with your kind permission, sir.
Yeah,
Yes.
go ahead.
So as Dr. Amitabh said that while answering to your question that if relative is asking whether the creatinine will come down or not, he said that because of the obstructing nature of the PCS of the stone. Again, we can also counsel because the patient is having uncontrolled diabetes and she is diabetic for last 7 years with poor compliance on her drugs, and she is having hypertension that is recently diagnosed. So I think in this scenario, these two conditions are more contributing to the CKD rather than the stone itself. Take any suggestions, sir?
No, I will like to mention only that in 1983, we have published a paper from All India Institute of Medical Science, in particular this problem, because at that time we used to see a lot of patients with kidney failure. We used to do only open surgery at that time, So we have published a paper, and there are 3 types of renal failure: acute on chronic, or chronic. So chronicity of the disease has to be seen. Second thing, whether the stones are obstructing means there is a dilatation of the pelvic calyceal system. Now, if you see this particular case, she had this renal failure for a long time. She has got this low hemoglobin also, and then she has got a tightly packed stone on the left kidney. There is no hydronephrotic changes. So what you are saying is right, that other comorbidities can also give rise to renal failure. Therefore, patient should understand before undergoing surgery that renal function may or may not improve, because patient relative may ask why you are operating if kidney function is not going to improve.
Dr. Amitabh.
Yes, sir.
What does the literature say? The published studies. What is the trend of creatinine in patients of CKD who undergo PCNL? There are quite a few studies which have been published. We presented our data last year. So there is some scientific evidence to this. So any idea about that? What happens to serum creatinine in patients of CKD who undergo PCNL?
Sir, sorry, sir, I'm not aware of, sir.
Okay. So there is a transient rise. On day 1, if you repeat it, it will be high. It should start falling by 5 to 7 days. And at the end of 4 to 8 weeks, either it is lesser or it's back to the same level which it was prior to surgery. Most of the studies would agree with that if it's a properly diagnosed case of CKD.
Yes.
Now we can shift the next student. Dr. Sanjay can join. Please put your audio visual on.
Yes, sir. Good evening, sir.
Good evening, Dr. Sanjay. So we'll take on Dr. Sanjay. So as Dr. Amitabh said, indications for active stone removal are stone growth, stone in high-risk patients, obstruction caused by stone infection, or symptomatic stones with the pain, hematuria more than 50%, and comorbidities, special situations of the patient, like patient is in a procreation, like pilot, merchant navy, and choice of treatment. So these are all the indications for the active stone removal. And obviously in this patient is having a large stag-on calculus on left side. She with a compromised renal function, she must undergo some treatment. So the plan was left standard PCNL with perioperative dialysis backup, as Dr. Amitabh said, after adequate glycemic control, obviously. So that was the treatment plan, and patient underwent this left standard PCNL with 2 punctures needed, one with the upper calyx, upper pole calyx, and the another was with the lower pole calyx, and the complete clearance was done. So Dr. Sanjay, I think it is.
Yes, sir.
So Samir sir already have actually asked Dr. Amitabh about the stone scores. Can you repeat or can you elaborate anything on the stone scores?
Sir, sorry that I don't have any other stone scores, sir. Yes, sir.
What are the stone scores you know?
Sir, one is the stone itself, sir.
Okay, so what does it stand for, stone?
Sir, as for skin to stone distance, sir, and
No.
It is
I think
sir,
if you
don't know
don't know, we
exactly,
can
sir.
move ahead. Yeah, if you don't know, we can move ahead.
Yes, sir.
Probably, but it's a good idea if you can go back and study them, because these are at least you should know that these scores as a MCH training.
Yes,
now, what is this? Would be a normal standard PCNL. What difficulties do you anticipate in this PCNL?
Sir, I have to first of all stage the procedure, sir, and explain the patient about this.
That has been done. You just tell me the technical difficulties which you would face.
Sir, first is during puncture, I have to choose the optimal calyx, sir, from which I can completely clear the stone, sir. First is the choice of calyx, sir.
Okay.
Then, sir, whether stone can be cleared from that calyx or not, sir.
Any difficulty in puncture do you anticipate? If you have chosen the correct calyx,
yes, sir.
Would the puncture be straightforward, or could there be a problem?
Sir, as the CT scan shows that there is no hydronephrosis, sir. So puncture will be difficult, sir. It will be stone guided, sir.
Okay.
Yes, sir.
Then what?
And the other, yes, sir. And other thing, during dilatation, as hydronephrosis is not there, sir. So chance of bleeding is high, sir.
So suppose you have punctured it and your guide wire is not going
because
of the stone. What would you do?
Sir, then sir, if my guide wire not pass into the ureter and just coil in the calyx, then I
No,
can
it is not.
dilate
It's not
over
going
it.
beyond the stone. It's not entering the PCS. Just at the tip of the puncture.
Sir, then I can dilate over that calyx, sir. Yes, sir.
The Bluetooth device is ready to pair.
Okay, all right.
Yes.
So,
Which dilators would you prefer?
Sir, Amplas sir dilator.
You mean the
metallic
Teflon dilators?
Sir, metallic dilator we use, sir.
Okay.
Metallic dilator.
In this patient, which dilators would be better, metallic or the Teflon dilators, the tapered cone dilators?
Sir, Teflon dilator would be good, sir, for this patient.
Why? Why?
Sir, metallic dilator will cause more trauma, sir.
No. The Teflon dilators have a conical tip. In this patient, where the system is completely filled by the stone, you're not able to enter the system. You would prefer to have dilators which are flat at the end. So metallic dilators would actually be preferable in this patient.
Okay, sir.
Okay.
Okay.
Yes, Himanshu, I think we can go.
Okay, so as Samir Trivedi sir said that metallic alkane telescopic dilators would be preferable. And so as I asked about stone scores, there are mainly two stone scores. First one is the Guy's stone score. There are 4 grades depending upon the number of the stone, size of the stone and location. The grade 1 is a solitary stone in the mid or the lower pole with simple anatomy, or a solitary stone in the renal pelvis with simple anatomy. So grade 2 is the solitary stone in the upper pole with simple anatomy, or a multiple stones in a patient with simple anatomy, or any solitary stone in patient with any abnormal anatomy like PJ obstruction also. So grade 3 is the multiple stones in a patient with abnormal anatomy, or a stone lying in a diverticulum, or partial stag-on calculus. These comprise grade 3. And the grade 4 is the stag-on calculus, or the any stone in patient with the spina bifida or spinal surgery. So it was added later on. So grade 4 is the stag-on calculus. So our patient lies in the stage 4, grade 4 Guy's stone score. And depending upon the Guy's stone scoring, the stone free rate and the complications are calculated. As the stone score increases, chances of complications and increase, and the chances of stone free rates decrease. Another one is the stone, STONE, that is the stone size, tract length, obstruction, and N for is number of punctures, that is the calyces, and E is the essence or the Hounsfield units. So these are scored or on the number of 1, 2, 3, 4, depending upon the stone size in millimeter square cubic, and the tract length in the millimeter, less than 100, more than 100, and so obstruction, none or mild and moderate to severe. If patient is having stag-on calculus, straight away patient goes into category 3, and Hounsfield unit. As the Hounsfield unit increase, stone score increases. So there was a study which I can quote, stone versus Guy's stone score, and it compared both the scores, and they concluded that they are both equally effective in predicting the success rate of the procedure. So coming on to what guidelines says, Dr. Sanjay, you see this patient, what needs to be done, which modality would you choose according to the guideline? So we have decided the PCNL, we did standard PCNL. Would you differ on this, like standard or something else?
No, I'd like to ask one question before that. Hello?
Sir,
yes, sir. Yes, sir.
When you have now heard that this has got a grade 4 score, lot of difficulty in doing the PCNL. Why
sir.
not open surgery in this case? Why you have not considered the open surgery option?
Sir, we can go for open pyelonephrotomy also, sir. But as the patient have comorbidities, sir, and with uncontrolled diabetes, sir, so chance of complication will be higher, sir. As PCNL is minimal invasive surgery, and we can stage the PCNL, sir. And sir, other advantages of open pyelonephrotomy, we can go for complete clearance can be achieved, sir, in one setting, sir.
No, I'm talking of this particular patient only. Apart from the diabetes, you have to control the diabetes well. Second thing, you have not asked any obesity. how obese is the patient, because
Yes, sir.
obesity is going to make the difference. And if you say ki PCNL is simple, you know, PCNL is also not simple in this case. She will need minimum 3 puncture, and
Yes,
she
sir.
may need 2 or 3 sittings. If you see the total stay in the hospital and all that, it will be 7 or 8 days. So keeping all these
Yes, sir.
factors in mind, so in a particular patient, especially, though it depends upon surgeon, what he want to do, what he is expert. But in a
Yes, sir.
place where person is not expert in the PCNL, he should not embark on the PCNL. Otherwise, the complications of PCNL can be more than open surgery.
Yes, sir.
So an experienced PCNL surgeon will be required for this.
Okay, sir.
Any comment by others?
Sir, please.
Anyone else like to make comment on this? Because that was my view.
That's fine, sir. What you said is, I mean, it's completely true that open pylonotomy may still have a role in selected cases. But you should also remember, Dr. Sanjay, that before you embark on an open pylonotomy, look at the stone
Yes,
and the
sir.
CT scan. It won't be an easy open pylonotomy. It's a completely intrarenal pelvis, and with the stone extending into the every calyx. So it won't be a very straightforward open pylonotomy as well. So you should have done quite a few open procedures before you decide on doing the open pylonotomy also. So get an exposure about the open procedures also if possible.
Yes, sir.
Coming
Okay,
on to
go
what guideline says. So I just wanted to ask what guidelines say regarding that kidney stone. So this is all about that if a kidney stone, except for the lower polar calyces, more than 2 centimeter, PCNL is the preferred treatment of choice. And for 10 to 20 millimeter or 1 to 2 centimeter, shock lithotripsy can be done, and less than 10 millimeter in the upper polar calyces, shock lithotripsy or the PNL can be done depending upon whether the distal passage is clear or not. RIS again has been kept accordingly. And as far as the lower polar stone is concerned, if the stone is more than 2 centimeter and less than 10 centimeter, it should be followed as above. If it is more somewhere lying between 1 to 2 centimeter and factors are unfavorable for shock lithotripsy, we can go for PCNL or any other.
There's some problem.
His internet is not okay.
Okay, that's fine. I think so.
Yeah, we can, sir. You can summarize, sir.
Conclude
You
now.
can summarize now. I think, Dr. Gupta, sir, you can, I think, summarize the main tips and tricks for the students.
These are the successful. So I would like to ask, what are the factors which would. Hello.
Hello, sir. Can you hear me?
Am I audible?
Yes,
Dr.
sir.
Sanjay,
Yes, sir.
you are audible. Himanshu, your audio is breaking
Am I
up.
audible,
There is
sir?
some connection issue.
Okay, sir. Am I
Sanjay, you
audible
are
now?
audible. Himanshu,
audible
your
now?
connection is slightly weak.
Okay, sir. Sir, am I audible now?
Yes.
Yes.
Okay, so these are the few like factors which impair the successful treatment, like long calyx or steep infundibular pelvic angle, or long skin to stone distance, narrow infundibulum. All these factors, they impair the successful treatment of shock lithotripsy. These should always be considered. So, sir, Anup sir, should I conclude?
You can summarize now. Yeah.
Okay. So there are PCNL nomenclature one should know. These are the like standard PCNL, mini PCNL, minimally invasive PCNL, ultra mini PCNL, micro and mini micro, and supine mini PCNL, depending upon the size of the tract dilatation. That is, the standard is beyond 24 or more, and then the mini PCNL is 22 or less, with minimally invasive somewhere 9.5 to 9.5, and micro PCNL 4.8, mini micro 8. So these are the nomenclature, and depending upon those, the stone clearance rate depends. So as it was asked that when metabolic evaluation is to be done, and in whom, these are the indications for the metabolic stone evaluation: in recurrent stone formers, strong family history, intestinal disease, or patient having pathological skeletal fractures with osteoporosis, history of any infection, UTI with calculi, personal history of gout, solitary kidney, anatomical abnormalities like UPJO, renal insufficiency, children and stones composed of cysteine, uric acid, and steroid. In all these cases, a complete metabolic stone evaluation should be done, and 2 consecutive 24 hours urine samples are required. And ideally, the initial specific metabolic workup should be done once the patient is stone free. So, general advice to prevent the recurrence, as we all know, is given to keep the fluid intake somewhere around 2.5 to 3 liters per day, and so that the diuresis of 2 to 2.5 liter per day is maintained. Neutral pH beverages should be taken, and the drinking of the water or the fluid intake should be in a circadian rhythm, not like that patient is just embarking for a water intake or the fluid intake in the morning or the evening. So it should be well balanced in a circadian pattern. Nutritional advice which should be given, that it should be the balanced diet, should avoid excessive vitamin supplement, should avoid excessive protein intake, should avoid excessive calcium intake, and sodium intake should be limited. So the diet should be rich in the vegetables, in the fiber, and limited salt intake and limited animal protein intake to 0.8 to 1 gram per kg per day. So lifestyle should be modified, BMI should be reduced, because the increased BMI has direct relationship with the formation of the stone and the chances of the stone formation. So what literature said we have already discussed. So imaging should be used.
You can stop here now. Okay.
Okay, sir.
This is all theory part that can be discussed later.
Sure, sir. Sure, sir. Sure. Thank you, and all the best for the.
Okay.
Thank you.
I want to thank Dr. Himanshu for excellent moderation of this case, and also our esteemed teachers for taking out their precious time for this wonderful program. Although I also want to thank the residents for taking up this Viva. So we were viewed by more than 400 students on different online portals. So that shows that they really have a good interest in learning. So I hope that the students have learned a lot in this program, and we will conduct more programs like this in the future. Maybe one more in this month and 2 more in the next month, before the final exams are coming for various institutions. So a final word of advice from our teachers they can want to give to our students, sir. Dr. Gupta and Dr. Sood and Dr. Samir, you want to give any final advice?
No, only I want to say that the boys should, because you are going to face 2 or 3 examiners at a time. And so you have to be mentally ready. There may be difference of opinion. So you have to restrict yourself to the question which has been asked to you, instead of just talking something irrelevant. Number 2, as an examiner, I am telling you, because examiner is not bothered what you are saying. He is only bothered to know you are not doing anything wrong. So if you are giving a wrong answer, he is going to trap you immediately on that. And then you will get lost actually, because you also lose your confidence. So try to do the minimum mistakes, keep the guidelines in your mind. And most important thing is follow what you have learned in last 3 years. This exam is not just for 1-2 hours or something like that. So you have to use your experience also, and along when you are answering these questions. And last thing I will say, to defend yourself, somebody, you maybe said something which may not be right. Then if you say in my institution, this has been, I have seen like this, then nobody will mind for that actually, because they will understand. And one thing more, if you don't know anything, be honest, say, sorry, sir, I don't know. So the examiner can ask you next question. Thank you very much.
Thank you very much, all the respected teachers for joining us today. I hope our residents have learned a lot from this program, and we see you soon in the next program. Thank you, everyone. Take all precautions, stay safe, and have a great evening. Thank you, sir.
Thank you, Anup. Thanks a lot, everyone.
Thank you. Thank you very much. Thank you, Anup. Thank you, Sudhir.
Thank you, sir.
Thank you,
Thank you, sir.
all the.
Thank you. All the best.
Thank you.